Thank you so much. So Santosh given me a job of how to triangle a patient for an appropriate procedure. So before starting, I just want to highlight there are different types of refractive error. There is myopia, hyperopia, and astigmatism. So first in the year of 1995, we started PRK. Then 2001, we started femtoLASIK. Flex, we started at 2007. Small incision lenticular extraction started at September 2011, which has been US FDA 2016. 2018 is a compound myopic astigmatism. And 2024 Smile Pro VisuMax 800 has been launched. So coming to the PRK, there are two types, alcohol assisted and trans PRK. These are some few of the issues with that post-operative pain, haze and regression. So with the microkeratome, LASIK used to be done, that is Amadeus 2 and Moria. There are the two popular microkeratome available. So we need to be always make sure that if the keratometry less than 41, always chances of free cap will be there. And more than 46, chances of buttonhole will be there. So this has been minimized with the femtosecond LASIK, which is bladeless, more accurate, can customize with the flap size and the thickness. So coming to the customized LASIK, that is wavefront optimized, wavefront guided and topo guided. So this is what why we go for wavefront guided, because of the no spherical aberration, which is based on the keratometry and the refraction that minimizes the spherical aberration, and also additional pulses in periphery and does not correct existing aberrations. So wavefront guided, which is based on the aberrometry on a higher order aberration treated on the cornea, that removes a lot of tissues, which is pupil dependent and accommodation dependent. Coming to the topo guided, started to treat irregular corneas, ablation pattern based on the topography, which saves a lot of tissues. So these are normal flexes. In femtoLASIK, what will happen sometimes, because of the cutting of the nerves, there will be a poor biomechanical stability, dry eyes and flap-related issues, which has been minimized in Smile. So the advantage of Smile, which is a flapless single step femtosecond procedure, the incident of less dry eye and biomechanically stable eyes. So coming to the one or two words about the presbyopia correction, you have got a Presbeyond, Presbymax and Supracore all on the corneal platform. On the less based platform, you have got multifocal IOL, trifocal IOL, you got EDOF. So one or two words about the Presbeyond, which combines both micromonovision and increased depth of focus by using MEL 80 or MEL 90 examiner system with the help of CRS master. Basically, you have to treat both the eyes, and 97% of the patient, they adopt this treatment very well. We make the dominant eye emmetropic and make the non-dominant eye myopic by 1.5 diopters, with where there is a blend zone where the vision from both dominant and the non-dominant eye meets up. So coming to one or two about the inlays, camera inlays are the most common one. We put it in the non-dominant eye under the flap. So the one more procedure, extra procedure, has become more and more popular. Especially it gives a stiffening effect only, no refractive effect. Especially patient with a thin pachy and early keratoconus, he can do this extra along with the Smile. So if patient is not suitable for keratorefractive procedure with the high myopia, dry eyes, extreme steep flat corneas, keratoconus, then the next option is the implantable phakic lenses. There are different phakic lens has been angle supported, iris fixated and posterior chamber. These are the few of the companies which is available. One is from the Colomar background and other one is all with the hydrophilic acrylic. So to achieve the best phakic IOL outcome, two very important, one is the antechamber depth, second one is the wide to wide diameter, and also perfect loading and intraocular insertion of the lens. These are the few advantage with the phakic lenses, with fewer induction of the higher order aberration, improved night vision quality, less dry eye and minimal wound healing and faster visual recovery. So keratorefractive surgery not suitable to ICL, or then you can opt for bioptics or refractive lens surgeries. So bioptics is a combination of laser and the lenses. Still patient not fit, then you need to think about refractive lens exchanges. So surgical option for refractive error have come a long way since 1990, which is more sophisticated, patient friendly in coming years. So coming to the main step, workup. So history, examination, investigation planning is very important. So preoperative counseling always very important. Always you should involve parents and attenders. Build and trust the patient with the patient. Very important. You can show them the booklets of the previous results. Then you need to ask the occupation of the patient also, very very important, and you need to take a refractive history since when he is wearing the glasses, and also history of presbyopia. Coming to the contact lens, those who are using the contact lens, you need to ask them, you need to stop the soft contact lens 1 to 2 weeks prior to the refractive surgery, and RGP or hard lenses 3 to 4 weeks before the surgery. So you need to ask for the ocular allergy history, ask for any eye rubbing, infection, and also ask for any ocular trauma is there. Especially you need to look for retinal tears, optic nerve atrophy, and also lens subluxation. So especially patient those are already having glaucoma, you need to always look for there will be steroid responder. Sometimes when you are putting a LASIK, suction pressure also it may increase and it may damage the optic nerve also. The advantage with SMILE, you will have a soft docking. So those who are already undergone previous glaucoma surgery, you need to look for bleps also and family history of glaucoma. That is very very important. Look for any of the ocular surgery previous happened, whether cataract surgery, retinal surgery. Some of the patient never tell that they come to, they might have had a RD surgery, it might be having a 6/6 vision. So you need to ask about everything. You need to ask the patient whether they are already have undergone the squint surgery. They may have a suction conjunctival scarring. Sometimes you may have find difficulty to put a suction ring. So in fact, you need to even ask a patient already whether they are undergone the pterygium surgery also. Those patients also will have a conjunctival scarring. So coming to the medical history, very very important. You need to look at whether they are diabetic or not. So then other thing is you need to look at the whether they are hypertensive, whether it's controlled or uncontrolled. Then you need to look at the pregnancy history, corneal parameters changes during the pregnancy. Always plan refractive surgery 6 months after the feeding over, and 6 to 12 months after the surgery, then you plan for pregnancy. This is important. So plan for pregnancy, and after pregnancy 6 months treatment is very very important. Then always look at the patient having whether other systemic condition like rheumatoid arthritis, multiple sclerosis. Then you need to about the wound healing and whether they are suffering from other disease like morphons. So also you need to ask about the drug history, whether they are on anticoagulants and whether they are on antihistamine, or whether some of the drugs may have a very poor healing also. Then whether they are having a somatotryptan where they may have chances of vascular occlusion, and patient even with the immunosuppressants they may have a chances of infection will be very high. So this is very very important. Then you need to ask about the history of epilepsy and 12 months to quit the disease. Then you need to ask about the especially for those are already underwent cardiac pacemakers, and also whether they are on any of the implants. So this is very very important. Then also ask for any herpetic infection, reactivation changes, and also whether they are on any of the prophylaxis for treatment. So coming to the examination, very important slit lamp examination. Always do a cyclopegyc examination for the first time, especially for hyperopia. Now look for pinhole also, and you need to look at for every refractive patient about the dominant eye testing, very very important. Then this is how you look at the patient, especially torchlight examination, very important, where you look for all orbital anatomy for small eyes, deep setted eyeball, prominent cheekbones, prominent nasal bridge, and also look for any of the squint and ptosis. So examination very important. So the slit lamp, you look at the lid, conjunctiva, cornea, tear film, lens, uveitis and antechamber depth, and also you do the intraocular pressure measurement, 90D examination. So dilator fundoscopy is very important. You need to look at glaucoma, or you need to look at the macular pathology, peripheral retina pathology. Always look for retinal break. Treat the peripheral retinal breaks accordingly. Counsel about the post-op prognosis also. So dry eye assessment is very important with all these tests. For every patient you have to do a Shermus, T-BUT, meibography and inflammatory markers. Then corneal topography is the most important workup to know about anterior and posterior elevation maps, to know about the anterior curvature map. That helps in especially detecting the early and the suspected ectasia, and also plan for the topo guided customized treatment. This is about the at risk corneas, what you can see in the this one. What is at risk corneas? Always keratometry reading more than 48 is at risk, anterior elevation more than 12 micron, posterior elevation more than 16 micron is very, very important. So what should be the post-operative expected key? That is myopia 0.8, hyperopia 1.2, and that is between, you can do around between 34 to 48 diopters. So suppose for example refractive error -8 diopter, then your keratometry may drop to 35.5. So this is about the pentacam picture. So pachymetry 500 micron. So always this is the Munalin for formulas. Always you need to look at how much every 1 diopter ablation in patient with 6 mm optical zone, then 13 micron will go. Then if it is 6.5, 15 micron will go, 7 mm, then 17 micron will go. So that is very, very important. Then other important factor is residual stromal bed. Always it should be around 300 only. Suppose if the, for example, if the -2 diopters, 2 into 15, that means plus -120 for the cap, that means patient is going to have a 344 residual stromal bed. This is how you calculate about the residual stromal bed. So apart from this, the one more important point you need to look about the percentage of the tissue altered, that is a PTA. PTA is equivalent to the flap thickness plus ablation depth divided by the central corneal thickness. So more than 40% of PTA, that is percentage of tissue altered, that means don't do the refractive surgery. If it is less than 40%, then you can plan for the refractive surgery. This is how. Then antechamber depth always should be more than 2.8 and white to white always between 10 to 13. So A scan to be done to know the ACD also. The other two factor pupillometry is very important. Always optical zone should be always larger, especially they will have a lesser aberrations. Then you need to look at the endothelial count of the patient also. These are the few investigations. So apart from that, you need to do the aberrometry, especially this is the one machine with iTrace. I don't have any financial disclosure that will know about the corneal aberrations, internal aberrations, and also dysfunctional lens index. So you can know the aberration profile also, so that you can plan. Then other equipment we can also help you, that is about the Corvis, where you can assess the biomechanical assessment to identify the risk corneas. So coming to few of the case scenarios I am showing you. Case number 1, this is a 24 years old female. The patient right eye refraction is around 2 and 2.5 diopter with the 1 and 1.25 cylinder. Central cornea thickness is around 4, right 497, left 500. So this patient, he can do any of the everything is normal. You can opt for either for LASIK, or you can opt for PRK, or you can opt for SMILE also. So case number 2, 30 years old female, football player. So normal pentagram. So you can either, since he is a contact sports, the SMILE or PRK is the best available options. Then case number 3, 31 years old female with high refractive error 11.5 minus 12 diopters, but ACD is very good 3.2 and left 3.1, then I think you should plan for phakic IOL. Case number 4, 24 years old female, minus 19, minus 18 diopters, but ACD is very poor, no laser, no ICL. If patient doesn't want to wear the contact lenses, then you should ask him for a refractive lens exchange. Then case number 5, 28 old female having a allergic conjunctivitis, eye rubbing. You can see the pentacam report not favorable, minus 3 with minus 3.25 cylinder, left eye minus 4.5, 5.5 cylinder, CXL you have to do, no refractive surgery for this patient. The case number 6 I am showing you, 23 years old male using spectacles, right eye minus 4, left eye 3.5, specular early fuchs, but still asymptomatic, then you can still plan for PRK, LASIK, or even for SMILE. Case number 7, 27 years old female with a pure cylinder, right 2.5 90, left 2 cylinder at 90, All other parameters are normal. So you can plan for smile after transposition, or you can plan for femtoLASIK or LASIK. So this is the last case. Male patient, 29 years, so history of spectacle 8 years, minus 3.25, 1.5 cylinder, left eye 3.5 with 1 cylinder, pack is very less, 434, 445, but ACD is very good. You can go for a phakic IOL. So always informed consent is very important. Pre-operative counseling, assess the patient expectation, explain the realistic goals along with the rare chance of complication of treatment, involve parents and attenders in the counseling process, build trust and rapport, promise less and deliver more. So 2 to 3 hours of detailed assessment for 5 to 10 minutes of procedure, which is the mantra for success. Thank you. I thank Dr. Santosh Honavar and all AIS governing body for this opportunity. Thank you one and all.
Thank you for that very insightful talk, sir. I now request Dr. Sushmita Kaushik to please join us on stage as the moderator for the session. Meanwhile, I request Dr. Arup Chakraborty to please take the podium for the second talk, that is calculation of IOL power, what is new.
So a very good morning, friends. I'll be talking to you on calculation of IOL power, what is new. Now this field of IOL power calculation is a very dynamic, it's a very happening field. You see software or hardware upgrades coming up in existing machines, or a brand new machine with a lot of additional features that come in. There are new formulas that have come in, or existing formulas have some upgrades. And then there are some newer concepts that come in. So basically, when I looked at the literature about 6 months back when I gave a similar talk, we see that most of these anti-segment journals or the other peer-reviewed journals have carried a lot of articles. For example, JCRS in May 2024 had 2 articles. In June, American Journal had 4 articles. And when I reviewed the JCRS this January, February, March and April, again there are 2, 3 and 6 articles. So it's a very happening field, and why is it like that? It's rightly so, because today cataract surgery is a refractive surgery, and we want to hit the bullseye at each and every time we operate, and our holy grail is plano 60 or whatever be the target refraction. You have to ensure all precautions and exercises to be taken to ensure that this kind of outcome. So where are we today? This is actually a landmark article, one of my friends, Giacomo Savini. So here, all the recent formulas were used, and the biometric indices were obtained from the sophisticated biometers. And it was seen that the post-operative, that prediction error, less than 0.5 diopter was seen in almost 90% of the patients. So this is quite a high achievement, So if we have, these are all for routine patients, normal patients. I'm not talking about, short eyes or very long eyes and, complex corneal scenarios. So if we have not reached this level, that means we have a long way to go. Now, if we are already operating at this level of post-operative outcome, I mean, have we reached the limits? It is generally felt that subsequently the increments will be very, very minimal, because, biometry, perhaps we have reached a limit in terms of the axial length. Keratometry, still, things have to be sorted out, so we need some better keratometric, inputs. There are certain uncertainties about, let me tell you about the uncertainties. Say, for example, most of these IOL manufacturers, they provide IOL in increments of 0.5 diopter, like say 20 diopter, 20.5, 21, or increments of 1 diopter for the very long eyes and very short eyes. So basically, if you have calculated an IOL power which lands in between, then you're forced to use a lens which definitely is a noise, and it'll land you in outside the prediction error of 0.5 diopter. So the manufacturers have to put in exactly the power that the particular lens carries. And then the labeling tolerance, the ISO or the FDA, they have allowed certain labeling tolerance, so that again, the manufacturer doesn't have to be very precise in putting down what exactly is the power of the lens. So because these are the things that have to be sorted out. In fact, though you're doing a very good biometry, all the precautions are being taken, but they're not, the IL technology has to catch up with us. The other thing is the effective lens position. This is, I think, is a very important issue because most of all the Virgin's formulas, they first calculate where the lens is going to sit, and then they recalculate what exactly is going to be the power of the intraocular lens. So this is effective lens position is important. Now I'll just show you 3 eyes, one with 11 diopter, 7 diopter, and 20 diopter. You see the postoperative position of the lens. This is a highly myopic eye. It is it is so deep. And again, a similar lens where the rexis size has varied, and again, you see the effective lens position, it goes meaningless, So this is something that has to be sorted out. And the newer things that are coming into the picture is, the influence of angle kappa and angle alpha, and the ocular biomechanics in IL part calculation. So literature is just waking up to these issues, and they're in the process of sorting it out. So you need to have a thought process shift. When you calculate IL power, it is just not a one-off event in the cataract surgery patient. It spans the preoperative period, the intraoperative period, as well as the postoperative period. So before you go for the biometry, you have to ensure that the patient doesn't have ocular surface disease. If it is present, then that has to be treated till you optimize the ocular surface, then go for the biometric readings and take multiple readings so that there is, some kind of a concurrence of readings, so they are reproducible. So you please do a nil touch biometry. That means, you do the biometry before doing any of the investigations. So that is also very important. Now, sometimes, we get into the habit of dilating the pupil, for getting proper biometric results, both for ultrasonic biometry as well as, optical biometry. In fact, with ILMaster 700, there's a study which shows that in certain cases where the signal is not good, if you dilate, you get better signals. But then, as I mentioned earlier, the biometry should be done before the eye has been, the corneal surface has been touched, has been modified. And then, this dilatation process can alter the biometric indices. For example, there are plenty of studies which show that after dilatation, the central corneal thickness, the anterior chamber depth, lens thickness, they alter. So if we use multivariate formulas which use all these biometric parameters and use the post-dilated values, 1/4 of your patient, 25% of your patients may land up with an overcorrection of 0.5 to 1 diopter. So this factor has to be definitely discussed with the patient. And sometimes we use artificial tears before the biometry, so make sure that, don't do your biometry immediately. We wait for at least 5 minutes. Now, once the eye is ready for biometry, then you go for, the actual testing. So we use optical biometer. This has become the standard of care, the gold standard. Many of us also perform a topography and eye trace to study the corneal astigmatism, the spherical aberration, and there are various other factors that are involved for advanced technology intraocular lenses. If the patient had been using contact lenses, younger patients, make sure that those contact lenses are removed for at least for a couple of weeks. The patient is on a hard contact lens. Now, as I mentioned that all of us have moved on to optical biometry, but I know that we are in a developing world and this is a very expensive equipment. So there is definitely a role for ultrasound biometry. If you're doing ultrasound biometry, do immersion scan. Don't get into the habit of, or get out of the habit of using contact applanation, because the studies have shown that with contact applanation, there is a mean average shortening of the axial length to the tune of 0.25 to 0.33 diopters. In a meta-analysis, Haigis had also shown almost a similar result, where the red bars that you see is with the ILMaster, and you get a level of accuracy, post-refractive accuracy with ILMaster. Now, ILMaster is not like a mantra that you put the patient on a optical biometer and you're bound to get perfect results. There are validation guidelines. So each value that is taken, measurement that is taken, we have to ensure that these values fulfill the guidelines. And if it is not fulfilling, then they have to be deleted and a fresh reading has to be taken. So this takes quite a lot of effort from the biometrist. Now, as I again repeatedly mentioning, that's the era of the optical biometers. Partial coherence interferometry came in 99. Then optical low coherence reflectometry, optical low coherence interferometry, 2009, 2012. But then now in 2014, we had the ILMaster 700, and there are a couple of other devices which are based on swept source OCT devices. So these are quite very expensive, and they do a lot of things beyond the biometry, and but they're extremely accurate, but they're pretty expensive. So I was quite interested in seeing this article in the American Journal this January, where it is a swept source OCT device, but it has a different mode of functioning, so that the device itself will cost not more than $2,000 if it is commercialized, which is less than the cost of an ordinary A scan. So let us see how far this study progresses. Then again, the axial length that we measure, most of the swept source biometers, other biometers, they give a composite axial length. That is, you assume the refractive index, same refractive index, and take the axial length measurement. Segmented axial length, or sum of parts, where each medium is the refractive index is considered, and then it is the thickness is considered, axial length is considered, anterior chamber depth, etc. It is summed up. So it is most of the formulas, current formulas that we will be seeing here, basically are based on composite axial length, not the segmented axial length, other than maybe the Argos machine and a new software that has come up with that particular machine. Now, regarding the formulas, there has been a very great degree of chaos. The earlier classification was generation classification, which was very chaotic. It didn't make much sense. 2014-15, Warren Hill and his team wrote a series of editorials in JCRS, where these are the classification system, which is based on method of calculating IL power and the data used for IL calculations. So we got used to this Barrett Universal to Hill, RBA, Olsen, Kane, EVO, Panache. But then last year, Giacomo Savini, he again classified IL power formulas in this pattern, and it is quite intimidating. But there is a pattern in the method in the madness. I'm not going through the details, but so many formulas are coming up, and gradually we'll get to know which formula is to be used for a particular situation. I would again suggest that all of you go for online IL calculation, because online IL calculation will allow you to refer to all these formulas free of cost in the various websites, and then you can use any formula and then take a decision. So this does not really, you don't get confined to a particular optical biometer. So various calculators, talked about the details. The go-to calculator is the Barrett Universal 2, which is available free of cost at the APSCRS website. It is a complete suite. All your IL power requirements are taken care of by this formula. Then again, AISCRS.org also gives you a wide variety of IL formulas, online formulas. Again, these are all free. IL calculators, post-op calculators, data analysis tools. The newer kids in the block now, they're doing extremely well. Kane formula, which is good for non-toric lenses. There's a keratoconus component. Then Hofford QST. Hofford Q is a formula which many of us use, but Hofford Q himself has condemned it altogether. But the people won't give it up, so he came up with Hofford QST formula. EACRS website was the only one which was lacking a IL formula software, IL formula link. So this came up recently, about a year back. So for the monofocal lens, non-toric lenses, you have to just fill in the data only once in the particular fields, and then it approaches all these all these 7 formulas, and then get you a result in one printout, and it becomes very easy for you to compare the various formulas and what are the intraocular lens to be chosen. For toric lenses, there are again 4 formulas that are used. So basically, what I'd like to conclude by saying, do I have time? 3 minutes? Okay. So another thing that we need to keep in mind is many times we can take advantage of the post-operative refraction in the first eye that has been operated. So there are a lot of supporting articles, and I myself follow this practice. So if the first eye has been operated and there's no refractive surprise, there is interocular symmetry, there's not been any transcription error, null malposition error, then I would readjust the target refraction for the fellow eye surgery to 1/3 of the refractive error that was seen, post-operative error that was seen in the first eye. I just change the sign, and that is going to be my target refraction for that. So second eye enhancer comes inbuilt in certain in newer formulas like Pearl DGS calculator. This we also have to keep in mind that there is an increasing awareness of the gender influence on the formulas. The Barrett Universal 2 is more accurate for the males, and all the remaining formulas, they are more accurate for the females, and this difference is more commonly seen when you're dealing with extremes of the axial length or anterior chamber depth. So friends, in conclusion, in terms of IL power calculation, please remember that you are in charge. You cannot put the blame on anybody else, optometrist or your assistant, because you have to take full control of the patient. So a proper patient workup has to be done in the preoperative period, the lines of what I have discussed here. Use appropriate measurement devices, use validated measurements, use newer formulas, and go online. and you'll get access to all these formulas that I've just mentioned. Work with properly optimized lens constants, adapt to new technologies as they present. Anything that is new need not be the best that is most suitable in your practice. So first try to see what the technology, how you can adapt to the technology, how the technology adapts to your practice, and follow that. And strive to use all available resources to their best advantage. Thank you so much for your kind attention. Any queries, anybody? Nobody's asking questions, huh?
Thank you very much, sir. We welcome our another chairperson, Dr. Mahimbal Sachdev, who is also the next speaker, enlightening us on recent advances in cataract surgery. Over to you, sir.
Thank you very much. I'll be talking about advances in cataract surgery. As you all know, that cataract surgery actually started in India, and that was with the advent of what is known as couching. And that was actually Shushruta who drew the attention to couching, wherein the lens or the entire lens without anything else was displaced into the vitreous. Then came what is known as the extracapsular cataract surgery. Then came the intracapsular cataract surgery. Kellman in 1967 came out with the concept of phacoemulsification. And mind you, it was again in India that you had the MICS, that is the manual small incision cataract surgery that came. And just understand that manual small incision cataract surgery came after phacoemulsification, because the concept of making a smaller incision came with phacoemulsification, and then people in Indian subcontinent switched to that manual small incision cataract surgery. Now these were, if you look at them, pretty much similar to what we use. These were the instruments that Shushruta used, and this is the lancet that was used for couching by Shushruta. So obviously the anesthesia, etc. program was there. So just to show you, I didn't have any recording from this, but so I picked it up from the net, and this is the way that the surgery was done. I think all the people who are on the dais would have done this. We had to put sutures, we had to make a large incision, and then the cryo, I still remember when we were residents, that's the time when cryo became popular, but a lot of it, along with the lens coming out, you had often in younger people the vitreous also coming out. So this was the kind of surgery that one would do, and then put the sutures, etc., and not implant an intraocular lens. Scissor vitrectomy was what was done when vitreous used to come out. Air tamponade was done. But the modern day cataract surgery, irrespective of the grade of cataract that you have, is what is known as phacoemulsification. I don't have any personal experience with small incision cataract surgery, manual, because we graduated straight from ECC to the phacoemulsification, and you can see that irrespective of the grade, even if you have a very hard cataract, you can actually break it, and the phacoemulsification procedure has changed from a high energy procedure, that means you were losing a lot of energy to break, to a high fluidic, that means a high aspiration procedure, wherein you are actually breaking the cataract into small pieces but sucking it out. So with maintaining the fluidic balance within the anterior chamber, that means that there is no shallowing of the anterior chamber despite you going to higher vacuums, as you can see here, 300, 400 with a 19 gauge tip. So this is the modern day cataract surgery, which is the phacoemulsification. Now just a couple of, since I have to talk about advances, in phacoemulsification and phacodynamics, as I told you, the three things that are important is, one, the fluidics, that is the aspiration flow rate, vacuum infusion pressure. This all determines the fluidics of it, the ultrasound energy, whether it is longitudinal, torsional, or elliptical, and the mechanical forces that you are using for this particular procedure. So when you are looking at the pumps, there was a lot of dispute as regards the two pumps which remained into vogue, which was the peristaltic, which is a flow-based pump, and a venturi, which is a vacuum-based pumps. I won't be going into too much of details, but both the pumps have some advantages. The venturi pump that you have, you don't actually need to have occlusion for vacuum to be created, while in a peristaltic pump, you need an occlusion for a vacuum to be created, and that is something important if you want to have a safer. But what has happened now in the advances of the machines is that you can switch between a peristaltic pump and a venturi pump. And that is something which you can see as to on what exact part of the procedure you are. If you want to go to irrigation aspiration, at that particular time you could switch on to the venturi rather than a peristaltic pump. So this is what is available nowadays in most advanced systems that you have. Now, as we all know that earlier there was only the longitudinal movement, and that was a linear longitudinal movement which was there in phacoemulsification. And what is kind of accepted today is lower power settings but a better fluidic flow. And for that, what has happened is that you came in with the white star technology, which is that it is no longer longitudinal, but comes as small little brief pulses, so that the total quantity of energy that is released is much less. And then apart from the longitudinal movement, what you have got is the torsional phaco which came in, or the ellipsoid phaco which came in. So you can actually, apart from the longitudinal movement, you can have a torsional movement or an ellipsoid movement, and that possibly gives better cutting ability. So this is something that has happened in the cutting. And then when you look at adaptive fluidics, the Centurion machine, now the Veritas, and now the Stellaris, they have now improved the capability of the sensors to sense as to when the fluidic balance is changing. That means that when occlusion is breaking and when there is going to be a compression or a shallowing of the chamber, and there can be gravity fed increase in the fluid or stoppage of the motor, or there can be more fluid that can be pushed in. So these are the couple of things that have happened, and these are called as adaptive fluidics. So you can now work with 400, 500 vacuum without shallowing of the chamber, which is something which is important. Now, coming on from the phaco, the next important leap that has happened is, I won't be going too much into it, but there is the imaging things that have come. So you have the Ingenuity, you have the system from the Zeiss, wherein instead of looking through the microscope, you are now having a 3D image, and you are actually looking at a screen to do the cataract surgery. This is something that has come in, but I don't think it has taken the phaco world by storm. The other important thing that has happened, apart from the imaging techniques, the biometer, etc., which was talked about by Dr. Arup so eloquently, you have what is known as the femtocataract. The femtocataract is something which is a complementary technique to phacoemulsification. It is not something that is substituting phacoemulsification, and there are 4 steps of the phaco procedure that are done by the femto. So that is the capsulorhexis. So that capsulorhexis, when you're looking at a catalyst system, you can see that it delivers a capsulotomy at 1.5 seconds. The importance of this capsulotomy is that you can center it on the pupil, you can center it on the limbus, you can center it on the scanned capsule, or you can customize it, and there is a mode called as maximize. So the pupil is small, you just press maximized, and it becomes smaller than the size of the pupil. So this is one first thing, that is the capsulotomy that happens. Then it fragments the nucleus into smaller pieces, and that again is up to you. How do you fragment, which is making it into quadrants or sextants or octants, and along with that you can see these small little pies that are created, and this is called as softening. So you can segment and you can soften the nucleus. That is the second part that happens in it, and therefore the quantum of energy that you are using for phacoemulsification goes down. So these are just the various ways. And third and fourth would be the incision and the astigmatic control, that is the LRI. So these are 4 steps that you have, which is done there. This is a liquid optic interface, the machine that I use, in which there isn't a gross compression on the cornea, but there is fluid, and the undersurface or the patient interface does not actually go and touch onto the eye. So you have a gentle dock with minimal IOP rise, and there is no corneal deformation. Patient comfort is good, And the femto laser, therefore, with these 4 steps actually makes the cataract surgery from a restorative, vision restorative procedure to a refractive procedure, because the outcomes are much better than before. So these are the 4 steps that I taught to you about: capsulorhexis, lens fragmentation, incisions and arcuate incisions. As you all know that if you do a capsulorhexis, which you have an in vivo image and you have a computer controlled rhexis, that is going to be much better than the manual rhexis. This is just to show you a femto procedure. This is, you can see that this is the pupil, this is the blue one is the limbus that is there, anterior posterior cornea, anterior posterior of the lens. You are making it into 4 fragments. You can see this is the capsulotomy. Normally we keep the capsulotomy at 5 because it tends to become a little larger. You can see the speed at which the capsulotomy was completed. You can see the nucleotomy which is being done. As and when the nucleotomy is completed, you can see that we go ahead and then this is the LRI which is done. In this particular case, we didn't do the incision, and then go ahead and do the same procedure as you do in phacoemulsification. Rhexis being pretty nice and good, so even if you have a PCR, you can cover up the, you can put the sulcus fixation and you can see the nucleus, taking out the nucleus is much easier, and then the irrigation aspiration gets completed, and then go ahead and put the intraocular lens which is there. Just to tell you that even rock hard cataracts, black cataracts, can be cut by a femto. It's only a white cataract which is difficult to cut because the focus, it does not allow it to focus onto the lower parts, and you can just see the air bubbles that are coming out and see a rock hard black cataract that has been pre-chopped and pre-cut by a phaco machine, by a femto machine, and this allows you to reduce the quantum of energy that is there. Now, just to tell you the other advances that you have in cataract surgery are devices that have come, these small little devices, even starting from viscoelastics, which I will not be enumerating, which helps in maintaining the chamber, which viscoelastic chondroitin sulfates helps in protecting the cornea and endothelium. But there are other devices that have come. There is another device that came, which is the zeptocapsulotomy, which is a precision pulse technology, which is accurate, reproducible, didn't gain too much because it was costly and did only the capsulotomy. And it can be used in fibrotic cataracts, and it can be a seamless integration. So there is a disposable handpiece, as you can see. There is a soft, clear suction tip. This is nitrolol. I'll just be talking about nitrolol again. This is the capsulotomy ring, and this is the incision finder that you have. So once you go with this particular thing, you can go ahead and with few milliseconds you can do a capsulotomy. So there's a suction ring, you place it on the lens capsule, and this is the time, the duration, the temperature, etc. that goes. I have no personal experience on this, and you can see in this particular case, this is the Zepto after staining, and you can see with one kind of just a pulse, you can get a great capsulotomy, which is this. So it is not something that is being touted about because it's expensive, was only for the capsulotomy, and there is a possibility of potential thermal damage to the endothelium. This is again a technique that came in. This again is nitrolol. This is by Zeiss. Again, hasn't gained too much of popularity. I don't know for what reason, but it's an excellent technique where you can see that this can even cut this nitrolol. You can see this is an almond that is being cut, and it can go ahead and slice these, because you just have to go in, go below the nucleus, and then you can slice the nucleus into several pieces. So this is a supari that one is trying to do. Obviously, you can see that there's a cleavage that has happened. Now, this is just to show you, after doing a good capsulorhexis, maybe slightly, there is always a fear that when you go down, you will rupture the capsule, but this is not really, it never ruptures because it's very soft and malleable. You go around, and then you can see as you go, there is a click at a particular point. You see, you go below it, and then you compress it. As you pull it back, you can see that it will cleave the nucleus into pieces, and it does that even to the hardest of the cataract. So you can see you have to just push the nucleus down, and then you go in, the nitrolol gets pulled in, and you can see that this is again a cracking of the nucleus. You see that it has cracked into several pieces. You can go ahead and again then do into 4 quadrants and finish up the surgery again at the end by using phaco. So this breaks it into smaller pieces. Now again, to show you certain other things which have happened, that helps you even in difficult cases. A patient had angle closure glaucoma, peripheral iridotomy has been done, and there was subluxation in this particular case. So you can use these rings which are available. You can see that this is a Malugan ring. You can use iris retractors, but not in femto, but you have the Bhattacharjee ring, which I'll be talking about. And with the small pupil also, you can do the techniques of femto, and you can see that because the pupil is large, you are able to get a nice, good rhexis, which is there. Now, this is once the femto has been done, you can see that this is the situation. You have the cuts. I'll just show you that here again, we are using an iris retractor to stabilize the capsule, but you can have capsular hooks to stabilize the capsule. And even in this difficult situation, you can go ahead and finish the surgery. As you can see, the endocapsular rings, etc., are there to stabilize. Now, artificial iris implantations are other things which have helped in cataract surgery. These are anhydric segments or anhydria lenses which are available and which can take care of patients who have loss of iris in whether it is traumatic or congenital, etc. So you can use that so that the amount of photophobia that a patient has or intolerance to light because of absence of iris is taken care of. So friends, to sum up, I'll just wish to say that there are several innovations in cataract surgery that have happened. IOL power calculation was talked about, the measurement of the IOL and the outcomes have become so standard today that cataract surgery is now tending to go towards results as you get in LASIK. LASIK within plus minus 0.5 was in a much, 0.5 diopters of emetropia was much higher than what was in cataract surgery. But now when you do everything properly, then you are able to get to the target of emetropia. Lenses will be the next, or both the things have gone hand in hand. The new lenses, which are presbyopia correcting lenses, etc., have also taken up the surgical level of the outcomes to much higher outcomes for patients and getting rid of glasses. One day I would feel, because of the improvement in the cataract surgery and because of the new lenses, we will all not be bothered about presbyopia anymore, and one would possibly be looking at refractive lens exchange as a standard of care. That's, I think, what I feel, and with artificial intelligence coming in, the outcomes would still be better for them. So cataracts, friends, is the largest in India. We do about 80-85 lakh cataracts surgeries a year, and this is a surgery that has really, India is really at the cutting edge of technology, and all technologies are available. Obviously, it's difficult to cover all the technologies, but cataract surgery today is giving exceptional results, and it has become a sophisticated, advanced, and easily accessible with excellent outcomes. Thank you very much for your kind attention. So these are just what I just talked, that these are the future breakthroughs that femtosecond laser, premium IOLs, AI advanced imaging, and future breakthroughs like adjustable IOLs, bioengineering corneas, etc. Solutions for dysphotopsia is going to take to still higher levels of outcomes. Thank you very much for your kind attention. Thank you.
Thank you, sir. Moving on to the next presentation, Medical Management of Glaucoma, the Newer Drugs by Dr. Nitika Berry.
A very good morning to all of you, respected seniors and dear friends. Professor Tanut sir could not be here today to present due to an emergency case, and I'll be speaking on his behalf. My name is Dr. Nitika Berry, and I'm an assistant professor at University College of Medical Sciences, and I'll be speaking on the topic, Medical Management of Glaucoma, Newer Drugs. I would like to start this talk on a little philosophical note. Just take a few seconds and think, why do we need these newer drugs? So a new drug always comes with a new hope, new opportunity, and new ways to improve life. So I request you all to tickle your gray cells a little and think, what options do we have in this regard? So anyone in the audience, can you just think what options we have in this regard? Or shall I help you with a few answers? Okay, let's take this up. And as we move forward, I hope it's more interactive. So the avenues available are, 1, modify the existing drug or the molecule within the existing class of anti-glaucoma medications to improve their efficacy. 2, improve the drug delivery of the existing AGMs. And 3, discover new molecules or anti-glaucoma medications. So MCQ, the recent format, which all of you are most familiar with, which is the most efficacious class of anti-glaucoma medication at present? A, B, C, or D? Anyone in the audience, please? It's a simple one. Anyone? Ma'am, sir, can you help me? So it is prostaglandin analogs, and let's just have a look as to what we have new with prostaglandin analogs, the most efficacious class. We have tafloprost. So the affinity for this drug is 12 times higher than latanoprost, and it is presently unavailable in India, but earlier it was there. We have latanoprostine bunod, which is a nitric oxide donating prostanoid FP receptor agonist, and we are awaiting its availability in the Indian market. So within this class of drug, take a moment to think as to how we can improve the drug delivery of this most efficacious class of drugs. So let's look at the patient-independent methods. We have 1, Duresta, 2, iDose TR, 3, punctal plugs, 4th, a bimatoprost ring insert, 5th, a spyglass IOL, and 6th, a CU lacrimal system. Let's discuss them one by one. So moving on to the first one, that is Durista. It's a bimatoprost intracameral implant approved by the FDA, has 10 micrograms of the drug, and costs around 1.5 lakh rupees, presently unavailable in India. So the literature on Durista, the trial says the famous Artemis 1 and the Artemis 2 compared the IOP-lowering efficacy and safety of the 10 and 15 micrograms bimatoprost implant. They found that the risk-benefit assessment favored the 10 microgram implant. So let's see the report card of Durista in the real-world study. So the single bimatoprost implant administered was safe and efficacious in reducing IOP for up to 1 year and decreased the need for topical anti-glaucoma medications. A head-to-head RCT trial between Durista and SLT, that is selective laser trabeculoplasty, showed that the bimatoprost implant was as good as SLT with IOP-lowering results for 2 years. Moving further to the iDose TR, that is a travoprost intracameral implant, FDA approved in 2023, has a travoprost drug of about 75 micrograms, costs about 12.5 lakhs, and is presently unavailable in India. So the literature on iDose TR, the trials, it showed efficacy that was equal to timolol over 1 year. And in fact, superior results of IOP lowering were noted when compared with the topical single monotherapy of prostaglandin analog. The real-world report card study said that a standalone implantation of iDose TR yielded a statistically and clinically significant IOP and medication reduction over 3 months. This slide shows the bimatoprost topical ring insert that is inserted into the fornix and is not very popular. The punctal plugs, that's another way of drug delivery that is placed in the inferior canaliculus, can give the drug for about 2 to 3 months, and you can provide drugs like travoprost and latanoprost. So a new thing in that is the CU lacrimal system drug delivery device. It was presented by Professor Malik Kuhuk. You would have known his name or heard his name by the famous KDB blade that has recently come, that Sushmita ma'am will be talking. And so the drug is delivered through the lacrimal system, and it's a slit lamp procedure, and hydrogels are there for sustained drug delivery. Another innovative method is the spyglass IOL that are under trials, which has an intraocular lens that is placed after a cataract surgery and has drug-eluting pads with a drug loaded that is bimatoprost. So a few early results are that they are expecting 3 years of drug delivery by this, but the official scientific reports are yet awaited. So now that we've talked about the patient-independent methods, let's look at the drug delivery on patient-dependent methods. So within the class of PG analogs, we have catiolance and microdose latanoprost. So Catalanze is a cationic emulsion of latanoprost. It's a preservative-free formulation utilizing cationic emulsion technology, which improves the tear film lipid layer, enhancing the medication's residence time on the ocular surface. And as we all would expect, that would improve the ocular surface parameters for our glaucoma patients, which is a huge challenge for them, as it's a lifelong medication they have to take. Microdose latanoprost uses the piezoelectric technology in which they're decreasing the drop size to about 8 microreters. So they're giving targeted delivery. You all should know that the conventional eyedropper is giving you about 30 to 50 microliters of that drop. And vis-a-vis the 8 microliters will decrease the side effect. Definitely you have better ocular surface with a similar biological effect. So let's take a quick breather from the whole list and take a moment to quickly discuss that what have we seen so far. So we've seen that the advantages of newer technologies are to overcome challenges like 1, compliance, and 2, ocular surface abnormalities. And the disadvantages definitely is the cost, and the cost. But I would like to reiterate that innovation is a state of mind, so don't get discouraged by the cost. As the people sitting over here, we are the ones that if we believe in innovation, definitely we'll come out with better cost-effective methods. So moving further, going back to our topic, drug delivery, other classes of anti-glaucoma medications. We have in the market the triple combination eye drop you might have seen. That is by Trisopt. You can see the Hindi name as well. So it is available in India, costs about $500, and it has brinzolamide 1%, brimonidine 0.2%, and timolol 0.5%. Definitely helps in the compliance of the patient. We have timolol microdrops. RCT done in South India evaluated the efficacy and safety of timolol maleate microdrops administered with a nanodropper. So the advantage was that the microdrop gave about 12.5 microliters versus the conventional we just discussed, 28 to 30 microliters. And they concluded that the timolol microdrops was equally effective as the timolol conventional drop with slightly less systemic side effects. So looking at a newer technology that helps us give targeted delivery are the nanoparticles. And in that, we have Timoptic XE, which is a pH-sensitive hydrogel formulation of timolol, unavailable in India at present. And now comes to the newer molecules of the drug. So the third category that we talked about, are the new molecules. So this is the most popular, I would say, recently, which you must have all used, and if not, you must use, is the Rho kinase inhibitors, that is nitarsodil, in a concentration of 0.02%. We have fixed drug combination of nitarsodil and latanoprost available with the trade name of Rocklanthin. And please note that both these above drugs are OD dosing, that is single dose, whereas you have the other Rho kinase, that is ripasidil, that has a BD dosing. So the mechanism of action is that it relaxes trabecular meshwork cells, which in turn improves the aqueous outflow, increases blood flow to the optic nerve, which in turn provides neuroprotection, and has some effect on the tenon fibroblasts, which can help reduce scarring of blebs as well. And important to the cataract and the corneal surgeon as well, improves corneal wound healing and endothelial regeneration. So now these are a few questions I would like to ask the audience. Which anti-glaucoma medication decreases episcleral venous pressure? Anyone? Please? Ma'am, can you help me there? Because, anyone? See, I'm asking questions because when I ask, you'll remember. Otherwise, you will forget. So the answer is nitarsodil, okay? So now question 2 tells me how awake you are. So what are the concentration of nitarsodil and ripasidil? That was in my previous slide. So anyone? Nitarsodil? Okay, it was 0.02%. And ripasidil? I can see you smiling, but you can answer also. Yeah? No? Okay, next time. So it's 0.4%. Okay, so another question, number 3. Mention another use of Rho kinase inhibitors other than the glaucoma. I'll give you a hint there. The last mechanism of action that we talked about. Important to the corneal or the cataract surgeon. Yeah. Come. Yes, endothelial. So post-cataract surgery, corneal edemas, you can give Rho kinase as well. And another MCQ question for your exams. So question 4, corneal verticillata is a common side effect of which anti-glaucoma medication? I'll give you a hint. We were just talking about it in the previous slide. Okay, it's nitarsodil. Okay, so moving back to our literature. So another new drug is omidenopic isopropyl. It's a prostanide EP2 receptor agonist. So what advantage we have is that it does not have the side effects of the normal PG analogs, that is the cosmetic side effects that we have in terms of prostaglandin-associated periorbitopathy. And it's acting on both conventional and uvascleral outflow. But presently not available in India, we are awaiting it. There's another drug called uniprostine isopropyl. It's a docosanoid and mainly acts in the conventional pathway by acting on the TM contractibility, again awaited in the Indian market. Now, this is a very interesting and an innovative technology that has recently got FDA approval for adjunctive use. It lowers IOP during the nighttime. It's an ocular pressure adjusting pump. And the recent results have shown that the IOP reduction exceeds 25% across 8 hours of continuous wearing during the nighttime. But further studies are yet awaited. Now, this is a quick list of the investigational drugs that I'll go through. This is for you only for that D-Viva or that shining gold medal in your exams if you're looking for. So the contact lens space delivery drug system is loaded with nanoparticles. You have drugs like timolol and PG analogs. These are under animal studies, subconjunctival drug deliveries through drug-loaded microparticles of dorzolamide and supraciliary injection of brimonidine-laden microspheres. You have nanosponges with intravitreal brimonidine, travoprost, and bimatoprost that have been tried. Okay, and this is a newer molecule that is recently being investigated, which is called cipatoprost. It's a dual agonist of the FPA and EP3 receptors. And it has shown, the recent studies have shown that it has a comparable IOP-lowering efficacy with latanoprost. And in 2025, they've also shown it to be comparable to timolol as well. So a quick note of, for completion's sake, stem cell therapy and gene therapy, they are under evaluation at present. And this is what I wanted all of you to know, that is lasers, okay? So the update on the LIGHT trial, that is the 6-year results of primary selective laser trabeculoplasty versus the eye drops for the treatment of glaucoma and ocular hypertension, they found that the health-related quality of life was, the differences was not significant between the two groups, but more eyes in the drops arm exhibited a disease progression. There were more surgeries that were needed in the drops arm, and there was no serious laser-related adverse events that occur. So they concluded that SLT, or selective laser trabeculoplasty, is safe for open-angle glaucomas and ocular hypertension, providing better long-term disease control than the initial drop therapy, with reduced need for incisional glaucoma and cataract surgery over 6 years. So how is it clinically relevant to us is that now we can offer our patients the choice of SLT also vis-a-vis the drugs with more confidence. So that's some food for thought as a newer thing. So I would like to summarize that we already have in our Indian market the Rho kinase inhibitors, Trisopt or Timolol microdrops. If you've not used, you are most welcome to try them. And expected in near future, the national and the international levels are these list of drugs. Thank you very much for your patient listening. Thank you.
Thank you, ma'am. That was a wonderful interactive session, at least from silence from their side. Next, we go on to premium IOLs and overview by Dr.
Can we have, because there have been several, you had five minutes for the discussion. Can we have any questions anybody has on the previous, 4 talks? Anyone? Any points anyone wants to? Yeah, please.
Good morning, sir.
Yeah, go ahead.
So, is there any role of robotic surgery in India, sir? Cataract surgery?
What surgery?
Robotic surgery?
Obviously, India, why are you? India is going to be the, what? We are the 5th largest economy. We'll soon be the 3rd largest economy. So all robotic surgeries are everything. Please do not underestimate. I think whatever you call femto, it's semi-robotic. See, there is the India being a country where there are still some bullock carts and there are the jet players. So I don't think we are behind any other country. So robotic surgery, AI, etc., everything is coming into India, and I think there is going to be a role, and there are going to be people who are going to be asking for that.
Arup, sir, will you do biometry in undilated position or dilated position in your patients?
Arup.
See, as I mentioned, I would like to do it undilated. Two reasons. One is, of course, you would like to do all the investigations on a virgin, pristine cornea. And second thing, as I mentioned, that after dilatation, certain biometric parameters, they undergo a change. And if you're using formulas which use those biometric variables, among almost 25% of the patients, they land up with a refractive error of 0.5 to 1 diopter. So as far as possible, I would like to do it undilated. But in certain situations, for example, if you're doing immersion, very hard cataract, and I know I'm not able to, my optometrists are doing it, they're very well trained, so we dilate the eye. Second thing is, even ILMaster 700, where, the good scans have not been obtained by advanced cataracts, there is some role for dilatation, where, you get better scans, and, at least, more reliable scans. But then again, it comes.
Thank you, sir. Thank you, sir. We move on to an overview of premium IOLs by Dr. Chitra Ramurthy.
A very good morning to one and all of you, and chairpersons and the moderators on the dais. So mind you, in the next 15 minutes to brief you about premium IOLs and what helps us to decide on which patient to select. So basically, we stand at a point in ophthalmology wherein we are planning premium IOLs largely to replace the cataract and give visual independence without glasses. And there is also a segment of patients, lens or may have very early cataract or a dysfunctional lens in the syndrome, wherein there is some aberrations which have started occurring in the eye, in the lens. So because of which the patient has a subnormal quality of vision and desires to have his cataract surgery done. So we have myriad of choices now. We have the monofocal lenses, which gives them good vision for distance. We have monofocal lenses with EDOF property that gives some range of intermediate vision. There are pure EDOF lenses. There are again hybrid lenses, which has a multifocality with EDOF property, and the trifocal lenses. Now, I'll be detailing you on all of these. But what is most important from that slide is there is a range of lenses which are available, and the very short counseling time the patient has with us, we need to convey it all. So we need to substantiate it with information which is there in the print media, the brochures, which is there on the social media, and every other way to ensure that the patient is well informed. When we talk of visual quality, it is a balance of three interrelated factors. One, you have to know the visual acuity of the patient pre-op based on the Snellens and the logmarks, and also understand whether what is the spherical aberrations which are there. Like a person could have, normally would have a positive spherical aberration in the cornea with the negative spherical aberration on the lens, which is getting counterbalanced. But as the lens changes start occurring, the aberrations, spherical aberrations in the eye, in the lens changes actually become from negative to positive. So there is induced spherical aberration. So you would look at implanting an intraocular lens in the eye, which has negative spherical aberrations, which will counter the positive spherical aberrations on the cornea. The other important thing, we also know there is something like chromatic aberrations, which is there in the human cornea, where that is why the blue light gets deviated most. So those optical lenses, which are going to have a high Abbe number, means that the dispersion of the light is going to be less. A low Abbe number means the dispersion of light is going to be more. So more the dispersion, more the chromatic aberration. So you would like to give a lens which will counter the aberrations of the cornea, which would have lesser chromatic aberrations. The most important thing is you need to know what is the efficiency of the intraocular lens which you're going to place, and that is the defocus curve, which I would explain to you. We also need to know what is the property in the optics, that normally when you start looking at premium opticals, which doesn't give vision only for distance, but also at intermediate and near, there are certain things in the optic where there is some amount of loss of light and loss of contrast sensitivity. So all of these have to be factored in. But most importantly, we have to thoroughly evaluate the patient, do a perfect biometry. We have to tell the patient that besides what you expect, there is some amount of brain adaptation which is going to occur, which will allow you to get a bifocal or a trifocal vision. And also try to explain to him the optics of the lenses to an extent that he has to be prepared with some kind of a glare and halos. So it becomes necessary for us to look at the tear film layer, the lipid layer on the meibomian glands, and treat it accordingly. Look at the cornea, whether the endothelial count is defective or fugues, which itself could cause glare and compromise vision. Do a topography to understand whether it is a symmetric topography, there is no irregular astigmatism. Do an eye trace to understand whether the higher order abrasions are more on the eye or the angle alpha and the kappa. And also do an OCT macula, whether there are some subclinical pathologies which would take away the contrast sensitivity, which might already be taken off by the premium lenses. We also need to measure both eyes. Even if the other eye is pseudophakic, it gives us a lot of information. Use the latest generation formula and treat the astigmatism, even if it is just 0.75 diopters. We need to understand the personality of the patient and explain to him what small quantum of quality of vision he might compromise with a particular premium IOL, and also convince him that neuroadaptation is effective. Now, a tall man who has a long outstretched arm would be fine to do a read on the iPads and may not mind wearing reading glasses for near vision, whereas a short guy who has a high myope, who has a habit of holding his books too close, would definitely want a vision wherein the distance and the near is very good. We also need to see what is the pre-op refractive error of the patient. A hyperope, a high hyperope, who's tired of wearing glasses constantly for distance and near, would be very amenable to going in for these premium multifocal or trifocal lenses, and so would a high myope be. But a moderate myope who enjoys to see without glasses for near, he would not be easily amenable, and you have to give him the best correction. So you also need to see the tried platform, hear from your colleagues, try it on your patients, look at which design of optics is more effective, and also understand the defocus curve. Now, defocus curve, I already alluded to, is a real world or the best objective measure to understand what is the range of vision of that particular intraocular lens. So how do you measure defocus curve? You correct the patient fully for distance, and then keep on adding a minus 0.5 diopter lenses in his eyes till the point at which he can still see. So that gives the range of vision to which, even after blurring his vision over the intraocular, the spectacle lens, he is able to see. And these are some classic defocus curves of an EDOF and a trifocal. Now, what other important thing? We already know monofocal lens gives great vision for distance, but keeps the patient spectacle dependent. So what we need to understand is, when a wavefront of light hits an obstacle, some portion of the light goes for distance, that is zero order, some portion of light goes for near, that is the first order, and some portion of light goes for very close, that is a second order. And that very close is actually a light which is lost. So what was seen was, in the bifocal diffractive lenses, 20% of the light is lost, and which is the reason for the reduced contrast. The other thing with the bifocal lens you also see is, there are two focal lengths. So when one object is in focus, the other object which is not in focus creates a defocused image, which is the cause for the glare. So then, of course, we need to understand. So what happened was, they came in with the low ad diffractive lenses initially, wherein to ensure that the dimmer image, the near image, does not compromise distance, they gave less energy, light energy was given to near. But then what it compromised was the quality of near vision was not good. Then came the EDOF lenses, wherein they used the optics such that the patient had an extended depth of focus, was available. So there was no overlapping of images which happened with the bifocal lenses. There was no secondary out of focus image. However, these EDOF patients had great distant vision, good intermediate, but the near vision was compromised. As far as the EDOF, just briefly understanding the different ways that these lenses were designed was, one was the play of spherical aberration. The positive and the negative spherical aberrations were played around with in a mini-well lens. There was the pinhole effect of lenses which was available with IC8. there was some lenses which gave a little lesser ad for near and gave that EDOF property. And there was a particular lens called Vivity, wherein they raised the platform and increased the curvature in the central part of the cornea, which gave a 1 to 1.5 intermediate vision. While all this was happening, there came the trifocal lenses, which gave great distant vision, near vision, and also a decent intermediate vision. How did it give us 3 points, focal points? Essentially what it did was it ensured that the loss of light was minimized in these designs of lenses, and these are the AT LISA, fine vision, and panoptics, wherein they have given the intermediate vision either as 80 or 60, in which they have optimized based on the needs of the patient. While this was happening, a lot more also happened. Then came the monofocal plus lenses, or the enhanced monofocal lenses. What they did was they just gave a little bump in the central optical zone, which gave a little 0.5 ad. So just gave that little bit of landing zone, a broader landing zone, great distance, and little bit of intermediate, which is provided with the iHands and the Vivinex Impress lenses. So then there were a lot of lenses for us to choose from. What was most important is we need to put the patient on a toric calculator and check whether there is astigmatism, and if that astigmatism is there, treat that astigmatism along with these premium lenses. Now I'm going to show you examples to make it more interesting. Now this is a 57-year-old teacher who wants to be off glasses, high plus power, a corneal endothelium is good, the macula is good, but then if you see the eye trace, you can see that the point spread is very disturbed, so must be because of the lens changes, and he has astigmatism, so we decide to put a trifocal in one eye and a trifocal toric in the other eye, and the patient was happy. This is fairly straightforward. Here, if one eye was seeing a little less for near, you could match it with a little micro monovision in the other eye and still keep him happy without mixing or giving another design of lenses. This is a 64-year-old retired man, father of a pediatrician, wants spectacle independence, but has to do night driving because he gets very nauseous if he doesn't drive because of motion sickness. But so for what we did, we noticed that the astigmatism component was not very significant, did an EDOF on one eye, but the other eye had very early cataract. We told him that we would give him a little monovision of myopia in the other eye so that he gets good near vision, and he was happy at that. This is another patient who is a 42-year-old female who wants spectacle independence. She has cataract only in one eye. We did tell her that all parameters were fine, but then she needs a cylinder correction, trifocal toric. Is she okay for those visual disturbances which might happen by a unilateral surgery? She was very keen on a trifocal, and she did well. Now this is another patient which I'm going to show you, wherein this patient is a farmer, okay? He wants spectacle independence. His eye trace shows lot of aberrations on his cornea. So then I would not risk it with this man. The topography is normal, but then the ocular health is also normal, but I would only place an enhanced monofocal, give him great distant vision, some kind of intermediate vision as a buffer, and just leave it at that, because aberrations do not go with these very high premium lenses. This is another female who works on the computer, again a high plus power. She's a diabetic, she has MACTEL and moderate diabetic retinopathy. No way would I put a trifocal, because a trifocal may compromise with a contrast. I would definitely put a trifocal, monofocal a toric lens for her. This is another patient who again is a male, has significant astigmatism, but has a lamellar hole in one eye, so he needs a combined vitrectomy cataract in one eye. The other eye, he needed a toric monofocal, and that's how we managed. So what you also understand while I'm showing you all of this, we need to do an OCT mandatorily in all patients, at least in premium IOLs, because in 13.7% of these situations, the OCT picks up a macular pathology which was not seen on a routine fundus evaluation. So you need to be so optimal in these premium IOL patient selection. This is a post-laser vision correction. Majority wanted mini monovision for the other eye, but there were patients who were ready to try a EDOF, and that was a popularity seen in this AAO Spotlight study. What is most important when you're doing a post-LASIK eye is, was the patient very happy with the quality of vision after his refractive surgery? Was the ablation bed fairly centered? No irregular astigmatism? No problems of near vision, night vision? He had a good ocular surface, a very highly motivated patient. go ahead and put a premium IOL. Of course, you need to do the topography. You need to look at the comparison between different biometers to see there's no irregular astigmatism, there's no difference in astigmatism between the two modalities. Now, this is a myopic LASIK patient. She has a little induced positive spherical aberration in her lens, so on a cornea. So what you would do is, you would want to place a negative spherical aberration lens in her eye. And majority of her lenses available have negative asphericity, and she could do well. And she wanted an EDOF toric and got done with it. Now, this is a hyperope, a 44-year-old hyperope. He has a central steepening on the topography, that red which you can see, and he has a lot of negative asphericity which is induced in the cornea. I wouldn't want to try a premium IOL. I would use an enhanced monofocal toric, which is also in the premium category. Finally, when would I put a monofocal lenses and still treat it as premium is when the patient has significant macular pathology, has glaucoma, post-LVC, has irregular bed, decentered ablation, corneal hyoid abrasions are less. These are the patients when I will say, please put a monofocal and not look at a premium IOL. So basically, the whole gamut of information which I tried to thrust to you in the last 15 minutes does tell us there's a huge range of development in the technology of the newer lenses which are coming in, but we have to customize our lenses based on the need of our patients, and if you have discussed it well and do an optimal surgery, you have done it all. Thank you. No questions?
Seems like they have learnt it all. Moving on to the next presentation is on approach to congenital and developmental glaucoma by Dr. Anil K. Mandal.
This is forward. Thank you for the opportunity. Dignitaries in the dais, friends, ladies and gentlemen. I have been asked to keep my presentation very basic, particularly for postgraduate students. So it will be very basic, approach to congenital and developmental glaucoma. The typical presentation is seen here. Congenital glaucoma is a rare disease, but it's a disease which occurs worldwide. Its prevalence has been reported to be 1 in 10,000 to 1 in 30,000 live births in the Western population. But a population-based study from India revealed that our prevalence in India is 1 in 3,300 live births. So we have a disease which is about, I'll say, 8 to 10 times more common than the Western counterpart. Congenital glaucoma is primarily a surgical disease, but surgery should be done at an early age as possible. That doesn't mean that we can send the patient directly from OPD to surgical room. No. Well-established methods should be applied to establish the diagnosis, rule out the other possibilities, and then plan for surgery. Now, it is basically related to trabeculodysgenesis, which may be associated with iridodygenesis and corneodysgenesis. Classic triad is epiphora, photophobia, and blepharospasm. And an initial examination in the office is mandatory, and in cases where examination under anesthesia is required, we should be able to do the examination and establish the diagnosis. We should proceed with a very meticulous and detailed method of evaluation under anesthesia, and proper equipment should be available like ultrasound evaluation, UVM, etc. And these are the differential diagnoses when conditions are associated with epiphora, blepharospasm, and photophobia. This is primary and some pictures of secondary developmental glaucoma. And when we come across, we used to, this is a very well publicized and well paper published to remember the differential diagnosis. I'll come to some differential diagnosis. this is a patient who was referred to us 2 hours after birth with a note that the patient is having unilateral congenital glaucoma, referred by an obstetrician who delivered the child. But, forceps application were there, and actually it is a case of birth injury mimicking primary congenital glaucoma. The disease appears to be more common in the left side because of LOA position of the presenting part. The other differential diagnosis may be CHED. In isolated cases, the ground glass appearance is very classic, and most important differentiating feature is normal intraocular pressure but very high corneal thickness. That is the thing. Some syndromes like mucopolysaccharidosis can present with hazy cornea, and we'll have to establish the diagnosis. Axial length, megalocornea, anterior megalophthalmos should be differentiated. Typical HAPS-TRI is seen here, and the intersegment OCD picture of HAPS-TRI is seen here. Corneal dimensions should be measured, refraction should be done, tonometry should be done, and we'll have to do a detailed evaluation of the anterior segment with the help of slit lamp or under operating microscope. Gonioscopy should be done, but a significant percentage of patients will not be suitable for gonioscopy in our patient population, because some of the patients will present with very severe degree of corneal edema, where gonioscopy and ophthalmoscopy is not possible. Ultrasound evaluation should be done. Here is a patient, there was total retinal detachment along with congenital glaucoma, and here is a patient who had posterior dislocation of the crystalline lens. Here is anterior dislocation of the crystalline lens. A very important diagnosis. The patient was referred with the history of typical feature of congenital glaucoma, but actually it was a case of posterior segment pathology. That's a ultrasound B scan revealed hyperechoic intraocular mass and diagnosed to be having retinoblastoma. Must be differentiated before we really plan for the management. And here is a patient, typical bilateral appearance, and ultrasound biomicroscopy revealed that there were iris cyst and secondary developmental glaucoma. So all these things should be evaluated before we really plan for management. When isolated trabecular dysgenesis is presenting with primary congenital glaucoma, the diagnosis is established and surgical treatment should be planned at an early age as possible. It may be associated with several other developmental abnormalities of the anterior segment. Is an important consideration. Corneal clarity, corneal diameter, and severity of glaucoma is an important consideration for the surgical approach we do. Most of the patients we see in India, we manage with primary combined trabeculotomy and trabeculectomy. I'll present a surgical video on that. Can you present the second part of the presentation? Yeah. So here is a typical case of bilateral primary congenital glaucoma. Now the question comes, what is the best primary surgical treatment? Because the first surgical treatment or the initial surgical treatment has the best opportunity for better outcome. Advanced cases may be there, and here is a situation, very advanced case of congenital glaucoma. When we inquire the history of surgery for primary congenital glaucoma, before 1938 there was no surgery described. The ultimate effect is blindness. But if we consider 1938 onwards till date, about 86 years history of surgery for congenital glaucoma. Started with goniotomy, trabeculotomy ab externo, primary trabeculectomy, combined trabeculotomy, trabeculectomy. A very important advancement came recently in the year 2010, fiber optic microcatheter trabeculotomy. And we, in the year 2022, improved the surgical technique for a special set of subset that is advanced case of neonatal onset primary congenital glaucoma, where illuminated microcatheter passage-assisted circumferential trabeculotomy was combined with trabeculectomy. I'll present the video on that. When Barkan reported his case in the year 1938, authorities from all over the world visited him, learned from him, like Robert Schaeffer, Arthur Lister visited him and came back to, Arthur Lister was from Moorfields, started the work in Moorfields in the year 1950s. Professor Sood, my mentor, did his FRCS in Moorfields in early 60s and learned the technique. Came back to India, started the technique. I learned the technique from Professor Sood. I'll come to the presentation, primary combined trabeculotomy and trabeculectomy in a separate video. I'm just presenting this case.
Is then made across the scleral spot.
Can we improve the sound? Yes, yes. Sound is there. Anyway, other videos are there, I'll come to it. So this is a patient of infantile onset congenital glaucoma of the left eye, and the patient came into the emergency. We diagnosed, operated on the left eye in the very next day, and you can see how dramatically the condition has improved over time. Can you present the sound also?
With appealing eyes, he speaks the language of his soul. The faces lit up with smiles, a radiant beam on the baby's face. Each little one, not a patient, but like my own child, does seem. These little gems are tomorrow's dreams. I cherish their budding beam.
So here is the photo essay presented in New England Journal of Medicine long ago. Here is the patient at the age of 10 years. So, you know, the outcome may be so good that here is a child at the age of 11 months after simultaneous bilateral surgery at second month of birth and dancing here. So I'll skip some of the slides here. We presented a series of 1128 eyes of 653 consecutive children done over a period of 21 years. The results are good. And here is a patient, 220 eyes of first 121 patients over a period of first decade, that is 1990 to 2000, who completed at least 21 years of follow-up. Here is a patient who completed 27 years of follow-up and is doing very well. A patient who completed 30 years of follow-up, and here is our results. According to last count, 13 of my operated patients are dentists, 7 did PhD, 11 are doctors, medical doctor, of which 8 did postgraduate medicine. Several patients are teachers, engineers, lawyers, journalism, chartered accountant, and self-employed. I am presenting the new surgical technique. Watch this surgical technique. Sound is there. Can you present the sound?
A drop of viscoelastic material was placed in the opening of the Slem's canal. 2 time forceps were used to grasp the illuminated microcatheter, placing the tip in alignment with the canal, and the device was advanced into the canal. The lighted tip allowed for the surgeon to visualize the cannulation of Slem's canal for 360 degrees as the catheter was advanced. The catheter was grasped with a forceps when it emerged from the distal end of the canal and was pulled out a little bit. Both the exposed ends of the catheter were pulled in opposite directions using a tangential force like a purse string.
2 by 2 millimeter trabeculectomy block was removed and an iridectomy was then made. A subconjunctival injection of 0.3 ml of dexamethasone was given in the inferior fornix. A poorly functioning distal outflow pathway will necessitate an additional surgical step that bypasses it, like trabeculectomy. This surgical procedure actually represents a microcatheter-assisted, novel, distinctly advanced, luminous technique that is Mandal technique suitable for advanced primary congenital glaucoma. Just 2 more minutes, an edited video of primary congenital glaucoma done on a patient whose both the parents were blind because of primary congenital glaucoma. Congenital glaucoma. Simultaneous bilateral primary combined trabeculotomy and trabeculectomy was performed on this baby at the age of 3 weeks when the body weight of the baby was 1200 grams. Compare and contrast the preoperative and the 3 weeks postoperative appearance of the baby. At 6 weeks postoperative, the child had total clearance of corneal edema in both eyes and the bleb appearance was satisfactory. The child is enjoying age-appropriate normal visual acuity in both eyes and the activity of the child is normal and the parents are extremely happy with the surgical outcome.
दो साल पहले मेरे बच्चे का ऑपरेशन इसी अस्पताल में हमने किया था जिसका नाम स्वर्णम है। आज वो 2 साल का हो गया है। ऑपरेशन इतना सक्सेसफुल रहेगा हमें उम्मीद नहीं थी, पर आज हमारा बच्चा हमारा कैसा सहारा बन रहा है आप भी देख सकते हो। कहीं पे भी मेरा बच्चा हमें हाथ पकड़ के लेके जाता है। ऐसा लगता है ये लकड़ी की ज़रूरत अभी 1 साल और रहेगी। 1 साल के बाद में अगर वो पूरा समझने लग जाएगा तो हमें ये लकड़ी की भी ज़रूरत नहीं रहेगी। हमारी लकड़ी हमारा बच्चा ही बन गया है। ऑपरेशन बहुत सक्सेसफुल रहा। आज हमारे बच्चे की हमको बहुत मदद होती है। घर में कोई बर्तन घूम जाता है तो बर्तन हमें ढूंढ के देता है। आज बच्चा देख सकता है तो हमें कितना खुशी होता होगा। आपको हम हमारी खुशी शब्दों में बयां नहीं कर पाएंगे। मैं मेरा पूरा परिवार रेलवे प्रसाद अस्पताल का बहुत बहुत शुक्रगुजार हूँ। विशेषता मंडल सर और उनकी पूरी टीम का बहुत बहुत शुक्रगुजार हूँ।
Thank you. The child completed 4 years of follow-up. This is the last photograph taken about a month ago. Thank you.
That is truly, truly inspirational, sir, and it pushes us to move forward, to do great in life, and to make a difference in someone's life. From that, we move on to minimally invasive glaucoma surgeries by Dr. Sushmita Kaushik.
Well, good afternoon, and thank you, AIOS, for the opportunity. And if you're really inspired, join us in this hall tomorrow morning on our session of childhood glaucoma, and I dare say that. So moving on to minimally invasive glaucoma surgery, I think you all are lucky to be in an era of glaucoma surgery which is way more exciting than what we came into with our trabs and tubes, full stop. But now you have the world in front of you. So I'm just going to give an update as to what things stand now. We'll talk about the glaucoma surgery. I'll possibly try to show MIGS in everyday scenarios, which we do, and what the current evidence as today stands. So glaucoma surgery is not an attractive one-time magic wand like cataract surgery is. There are risks and complications. There's issue of adequate training for glaucoma surgery. Most residents worldwide, and it's not just here, get very little hands-on glaucoma surgery experience. The problem is it's not a quick fix situation. You have to work much harder in the post-operative period for the post-operative management. You have the problem of scarring and failures, and if you follow them up long enough, you'll have many more failures, and that's the sobering fact. The other problem is the patient has a false sense of complacency. He thinks that the surgery is done and the glaucoma is cured, and that's something which you really need to counsel them, that we've only brought down the pressure, but the disease may still overtake what we've done. So trabeculectomy was is rather our backbone of glaucoma surgery. The problem is there's a propensity to fail by scarring. There are complications. It's a lifelong ticking bomb, actually. If there is excessive filtration, you can have a choroidal detachment, hypotony, and loss of the eye. There is this risk of a bleb leak and infection, which stays lifelong. Now, this patient has come about 20 years after a very successful trabeculectomy was done long, long ago. So you're never really rest on your laurels if you've done a trabeculectomy. But then, don't get me wrong, trabeculectomy is still our savior. The vast majority of glaucoma patients that we see are like this. They're advanced glaucoma, they're poor, and they're unable to afford medications or be on follow-up. So for a patient like this, now this is characteristically of a patient who comes to us with split fixation fields, near total cups, and there's no point doing an OCT in them. That's another story. So the best thing that we did for them is a phaco-trab. And this is 8 years later, and you can see those are the fields that he's come with, and these are the fields recently. The vision is okay, the pressures are fine, the visual fields are stable, and the blebs are still working. So for a patient like him, which is actually the vast majority of the glaucomas that we see, doing a trabeculectomy is almost life-saving because you've saved the vision of whatever the vision was. Dr. Mandal has just taken us through how the children are a different challenge. It is one type of glaucoma where we are not bothered about a pressure, we are bothered about vision, we are bothered about an entire lifetime, and ab interno procedures would be desirable in them if you could spare the conjunctiva. So coming on from the children, the idea is spare the conjunctiva, and that is where minimally invasive glaucoma surgery comes in. It's minimally invasive because it is minimal disruption of the conjunctiva, the sclera, and the iris. The usual angle-based surgeries bypass abnormal TM or trabecular meshwork. So you have to understand that if you're just treating the angle, you're bypassing the trabecular meshwork, assuming that the distal outflow channels are normal, and that's not always true. Whereas the translimbal surgeries bypass the normal outflow completely, but the downside is that they have a conjunctival filtration bleb. But then none of these precludes further surgery. So even if you're embarking on your mixed journey, you have to tell the patient that I'm going slow, I'm going least, I'm going minimal, I'm not, and the way I tell them is that I'm first going to try with a pistol rather than hit you with a cannonball, and if the pistol works, then it's fine, but we do have cannonballs and we do have larger surgeries really to tackle your disease should the small one doesn't work. So the options that you have, this is an easy way to remember. Angle-based, like we told you, bypasses the trabecular meshwork. So you have a goniotomy. You can have bank, bent, ab interno, needle goniectomy, which is a little bit of an extension of a goniotomy. You can have GAT, which is 360 degrees, a gonioscopy assisted transluminal trabeculotomy. This is a 360 degrees goniotomy. The trabecular meshwork can be stripped off with a Cahoog dual blade. It's called a KDB. You also now have the Tenito hook, which is available in India, which is a little similar to the KDB, but according to the Arvind group, it is smoother and the results are good. And then, of course, you have the trabectome. Again, taking off the trabecular meshwork but using plasma energy rather than just mechanical stripping. That's the only difference. And then there is a variation of the Trabex where you don't have the plasma, but you just have the mechanical and you have irrigation along with it. So the ticks are the things that are available to us everywhere. You can go into the trade and pick up any of these things. That's freely available in India now. The canal-based surgeries are those in which we insert a device into the Schlemm's canal, again bypassing trabecular meshwork. The only one available in India is the iStent, but the hydrus and the canaloplasty have also been shown to be good for that. And then, of course, the translimbal fistulizing, we don't have these devices, but the prototype is the Zen implant. It started out being an ab interno procedure, but it had a problem of getting stuck in the tenons. So now it is actually being done ab externo as well. And the pressor flow microshunt, a tiny little device, which is used once you open up the conjunctiva, and it's like doing a micro trabeculectomy. Now, the prerequisites for a MIGS, of course, is a direct gonioscopy. So the first thing you need to do is you need to rotate the head of the microscope, and you need to rotate the head of the patient. And I'm showing a baby because we do gonioscopy often, and that is the most common MIGS that we do in children. And then you need a direct gonio lens. So my favorite is a Swan Jacob, but you can use any direct gonio lens, and that's how it's put on the cornea underneath a coupling fluid. So these are the prerequisites you need before you start on MIGS. So you need this. Then the surgeon's position is a little different. So you can see the microscope is tilted. This is Ashok. He was our fellow. He's just joined us as faculty. I'm sure in the next couple of years you'll be hearing a lot about him, and from him rather. So here the microscope is already tilted. The head is tilted to the opposite side. The surgeon sits directly opposite the angle to be operated. Now you have to understand that if you don't tilt the head in the first picture, that's where the angle would be. So you need to tilt it so that you are end on, looking in on the angle when you're doing your gonioscopy. And this is with him operating the left eye. And on the microscope picture, you can possibly see the angle. And that's how you see the angle while you're operating. So this is just before he's going into the angle to operate. When we do a goniotomy, we try to do as much as possible. So this is in a patient he's a child, but you can see the iris fall back. So those arrows show you the iris falling back, and you can see the cleft being formed. Can you see that? So that white thing that you see behind is a cleft, and this is really the mother of all your MIGS. If you can do a goniotomy well, you have started your MIGS journey, and this is the simplest one to do. So this is what an Axenfeld-Rieger looks like before a goniotomy, and once you make the incision, that's what the cleft looks like after that. The iris falls back, and the trabecular meshwork is bypassed, and the cleft is opened up. The bent angle needle goniotomy is what we do in adults. It's an extension of a goniotomy, except that the trabecular meshwork is not sliced, the trabecular meshwork is stripped. So this is how we go about it. Under a coupling agent, your Swan Jacob has gone in. This is a 25 gauge needle. It is bent like a reverse cystitome, which means that the smooth side is on the outside. And in a minute, you'll see the TM come at the tip of this. So you'll see the TM, and that's the trabecular meshwork. Can you see that? That's a trabecular meshwork at the tip of this needle. So you've really stripped out a trabecular meshwork. One tip I can give you, which I give my fellows, is do not feel tissue. If you're doing a bang or you're doing any MIGS surgery and you're feeling tissue, you've already gone into the sclera. And the reason why your MIGS will bleed is if you're scratching sclera and you're not looking at trabecular meshwork, because the TM, remember, is avascular. So if you do a clean and you do it under visualization, you will see the TM come out cleanly like that, and you've just stripped off the TM without having any bleeding or anything from the sclera. The trabectome is much the same. It's a much more costly thing, 30,000 rupees for one set of the tubing and everything. So we've exhausted all of them, and we don't ask for anything new. But if you can see the plasma energy there, so at the tip of that trabectome, instead of mechanically stripping it, you can see the trabecular meshwork has been stripped, and that is bare, but it's been stripped using plasma energy at the tip of this blade rather than mechanically stripping it off. But frankly, in our experience, we haven't seen much difference, so we haven't really insisted on the trabectome being bought again. So this is my favorite surgery by far now, my favorite MIGS for anybody, children, adults, JOAG, steroid. It has changed the practice because it has allowed me to stop doing conjunctival and scleral surgeries as much as we used to. Early days yet, but the first couple of years have been very, very nice. So this is a 360-degree ab interno trabeculectomy. There's no extra equipment required. We do it with a 5-0 or a 6-0 Prolene. So basically, this is done in a phakic patient. So you use pilocarpine to constrict it. 2 incisions made, and this is a blunt-tipped Prolene, which is to be blunted with a little bit of heat cautery so that it's mushroomed and it doesn't really cut through the schlems. And this is the initial goniotomy. So remember I said that's the mother of all MIGs. You have to know goniotomy to be able to carry on. So that's the first goniotomy being done, and I'm pulling the trabecular meshwork a little down so that you can see the sclera behind. A bit of viscoelastic to give us a little bit of cushioning there. This is a micro-incisional forceps. Your vitreoretinal colleagues will have that. You catch hold of the edge of that Prolene and you start threading the canal. It's a very elegant procedure. It has a bit of a learning curve, but believe me, if you do it, there's nothing more enthralling than to see it come out through the other end. So I'll just show you that in a minute. Can you see that? Now it's come out 360 degrees from the schlems, and you just pull down externally. The entire 360-degree trabeculotomy is done. So this was an adult, a JOAG case, so you can see the cornea is reasonable. I do wash out the viscoelastic because I'm scared of the IOP spikes, especially in juvenile open angles. But like I said, if you do it well and you don't cut through sclera in your first incision, it really doesn't bleed. So don't be scared, even if you have hyphema initially. Once you get the hang of it, it doesn't, and you just need to hydrate the ports and the surgery is over. So coming to the eye stent, it's a trabecular microbypass shunts. The fact that they come out with a new thing every year shows you that it's not particularly, and no financial interest either way. I'm neither paid to say it works and nor paid to say it doesn't. But the fact is that you had an eye stent, then you had an eye stent inject W, and then now you have the eye stent infinite. So this was the first one. Then you have the inject, then you have the inject W, and now you actually have three that you can put 1, 2, 3 at a time. I borrowed this video from Dr. Pandav because he possibly has a couple of rich patients who afforded the eye stent. Yeah, okay, so this video is working. So it's like a gun, and both eye stents are in one piston, and you shoot one, and then it goes, there it is, in the trabecular meshwork into the canal, and then you move across, and then you give another shot, and there it is. So this is an eye stent inject. It's not the W, it's the inject, which has 2 of them. The infinite has 3, so you can go another 90 degrees and inject the third one in the same way. Right, so how does it fit in? Of course, my babies are my heart and soul, so we looked at how goniotomy works, and at the end of a year, one goniotomy bilaterally had about, in 76% of the babies, that's all they required, and 2 goniotomies had a 90% success, which was what is published worldwide. We did an RCT. We actually took babies with very similar primary congenital glaucomas. We did one eye goniotomy and one eye bang, because we thought stripping the trabecular meshwork would be better, but to our surprise, it makes no difference. So in children, at least, with a stretched elastic eye, just doing a goniotomy is enough. You don't really need to do a bang. So any patient with cataract and glaucoma, the best case scenario for me is a moderate glaucoma with open angle. So 63-year-old, 624, 618 vision because of cataract, 16 millimeters on prostaglandin analogs, 0.8 cup, and a PSC, for me is a best case scenario to combine a cataract surgery with a MIGS. What we do most often is once I'm going in and doing the phaco, I would go in and do the bang as well. For me, it's a 5-minute or a 3-minute extra thing, and it makes so much of a difference if I can take them off. That little bit there is a trabecular meshwork, by the way. I always do my MIGS before doing phaco, because I think once you have the fluidics of the phaco going in and with the viscoelastic in, it doesn't ever bleed, and at the end of the day, there is no hyphema, or at the end of the surgery. Whereas for me, at least in my hands, if I do the phaco first and then the MIGS, the eye is not virgin, it's a little unstable, and invariably there's hypotony because of so many ports. So can I take a minute more? I'll just completed, right? Okay, I thought that was a bell. So these are what the patients look like next morning, no drugs, and so far so good. About a year on, we've been able to take about 70% of our patients off glaucoma medications when we combine a MIGS with a cataract. Surprisingly, in primary angle closure glaucoma, and slowly the world is waking up to the fact that PACG is a good candidate to do MIGS despite what you'll read. Maybe you shouldn't say this in your exams, but let me tell you, everybody who does MIGS cannot shy away from primary angle closure glaucoma because it's 50% of our primary glaucomas anyway, isn't it? So this patient actually underwent a phaco and a trabectome when we had one of those sets, and he did so well that we sort of went on to try and do more things, and invariably we did think it was reducing medication. Now this woman actually was status post-trab, and she's 18 on Diamox and 4 meds, but she's 6'6" with a clear lens, and I don't have the heart to take out a clear lens even if she is post-trab. What do we do? Revise the bleb, do a retrab, do a tube. How about MIGS? And we actually did a trabectome in her, and surprisingly, this is de novo trabectome with the lens in place because she was 6'6", and we could take her. So this POD1 was a little messy, but by 3 weeks, so far so good, and she's still about 8 millimeters of drugs, and we hope we'll be able to carry on with that, and that's the angle. So saying that you cannot do a MIGS surgery in primary angle closure is not true. I'll show you a couple of patients with synechial closure. So this is the kind of PACGs that we get. You can see the disc very hazy because of the cataract, but you can see a completely closed angle. And this is not appositional, it's not going back. And you can see with the long-term angle closure, actually the posterior synechiae have also formed. So I'll just go through this. Okay, so I just want to show you a goniosynechial lysis. You can actually just pull it down with your bang needle, open up the trabecular meshwork and strip it. And believe me, I think primary angle closure is a primarily trabecular disease, and the outflow is better than the POAGIs, so the MIGS works really well. So this is stripping off after doing a goniosynechial lysis, and we always follow up our phacos after that. And once we do that and we do the phaco, they really, really do well. So this is how she was. She has no PL in one eye, but we managed to get her down. This is first post-op day, and down to 1 medication. So this is our preliminary experience of phaco bang with 1-year results, 30 eyes of 30 patients. It's important to note that there's not much you do with the pressures because that's not your game. That's not your end game. If you have uncontrolled pressures with a cataract, we do a trab. I'm talking of patients where the pressures are controlled but on 4 medications, with Diamox, with everything. This is where your success rate is. This, your AGM use, your anti-glaucoma use comes down, and your patients will thank you forever. And this is an example of a patient who is like this on 4 meds. If you take him off meds after the cataract surgery, 15 millimeters on 4 drugs, 15 millimeters on no drug, that's a great outcome. So you should aim to do your MIGS with your cataracts. We do a GAT when you want to do more than a goniotomy and you don't want to do a CTT, that's the indication in children. And it also works surprisingly in PACG. So I'll just run through this. There's a bit of a hyphema here. I'll run through this again, phakic, 6'6" vision. We did a GAT and she actually works, and 15 months later, her pressures are still controlled on no drugs. Having said that, you must know regulations. We don't have regulations for MIGS in India as yet, but you must know what FDA regulations are. It is not approved as a first-line treatment for mild to moderate glaucoma without prior medical management. So at least FDA doesn't approve of it as a first line, unlike the SLT. And combining multiple MIGS in the same eye on the same day is also not approved. So you can't do an eye stent and a KDB, for instance. You can't say, I'll put in an eye stent and I'll do the rest of the KDB. Insertion of a Zen stent, this is so important, requires an ophthalmologist experience in trabeculectomy and bleb management. Because if you're doing outflow like Zen and pressor flow, you have to know how to manage a bleb. Now, these are FDA regulations for a MIGS. And the coverage, at least in the US, is limited to 1 eye stent infinite or 1 Zen gel in per eye. So you can't do an eye stent and then do a Zen in the same eye. You'll have to do something else. I'm just bringing in current status, which is 2025 scenarios. This is the American Academy of Ophthalmology's Glaucoma Preferred Practice Pattern Committee. And I think the most important thing that they've understood is what I just said. Surgical success for MIGS, combined phaco, it's called cataract extraction IOL, is defined as a decrease in glaucoma medical therapy of one medication or more from baseline without an increase in IOP. And that is a success criteria, which is different from the success criteria, which is the usual one, which is number 2, an IOP of 21 millimeters or less and reduced by 20% or more from baseline. That is what a glaucoma surgery success criteria is. But for MIGS, a success criteria is without an increase in IOP, if you can bring down AGM use, that is a success in MIGS. And that's important because you are coming to an era where you will be also concentrating on lesser and lesser drugs and better outcomes. So MIGS phaco versus MIGS alone and angle closure, there is superiority of MIGS phaco versus MIGS alone. Phaco GAT versus standalone GAT, there is comparable IOP and AGMs, but there's better vision in phaco GAT, obviously, because you're taking out the cataract. And in the Hydrus versus the iStent inject, there's superior IOP reduction and significant reduction compared to the iStent inject W. So these are the current 2025 long-term papers which have come out on different MIGS for different conditions, but the most important for us is primary angle closure disease. There is evidence that there's superiority of MIGS phaco in a primary angle closure disease, so try to incorporate that in your practice. Early days yet, but preliminary thoughts are children, yes, always. Planning cataract surgery in a patient with glaucoma, even PSEG, do a mix. Reduce, wean off medication, avoid incisional surgery. Clear lens, if you do a trabectome, there's less bleeding. Anything with a clear lens in a POAG always reduces medication burden. Thank you. It offers a balance, and I'm happy to be here. Any questions?
Any questions for Dr. Sushmita? We have time with this. So Dr. Sushmita, I have a question for you. Since you started performing MIGS, what percentage of your trab has been converted to MIGS? The numbers, if you remember them.
Earlier, we wouldn't do a trab if the pressure was controlled on 3 drugs. So the indication of trabs is uncontrolled medical management still. If it's uncontrolled medically, then we wouldn't do a MIGS, we would do a trab. A MIGS in our scenario now is controlled, but on 4 drugs. Controlled, but on 5 drugs. That is the indication for MIGS. But uncontrolled medically, I don't think the MIGS would work there. The outflow is completely gone. Having said that, any cataract surgery that I do, the incidence of phacotrabs has gone down drastically. Because if I do a cataract surgery, I would always combine a MIGS or a bang or a GAT in a patient. And now that we started doing phaco GAT, maybe next year I'll tell you how many trabs I've stopped doing. But standalone, on Diamox, uncontrolled, advanced glaucoma, I wouldn't do a MIGS. That indication stays.
Any other questions for her?
Maybe Dr. Harsh's comment on.
The American Academy report that you showed, you just showed the criteria, but what are they saying? Like the 24 report was pretty damning, and which said that cataract itself lowers much more than the MIGS. So what is this report saying?
The evidence says that if you combine a MIGS with cataract, the lowering is much more than a cataract alone.
The prior report said that the lowering was only 1.2 to 2 millimeters if you add these trabecular, especially the iStent and the other one.
I'm sure the iStent, but I'm not sure about the trabecular stripping ones because I'm
stripping
sure
one
with the phaco, because
in
of
America they'll not do it because it doesn't make money.
Yeah, but they have started doing a lot of phaco GAT, sir, because the money is in the eye track now.
Yes.
So they've started doing a lot of GAT.
Yes.
It's $1,200 per
Great,
eye track.
great.
So
Yes,
now they're
we
doing
have to
that.
find some money in glaucoma.
Yeah. No, we found a lot of money, sir, with the MIGS in.
Well, thank you very much, everyone. Yeah, good. One for the road.
A question for you, ma'am.
Yeah.
So, ma'am, I would like to know for how long is the IOP lowering effect of phaco MIGS or standalone MIGS happening? I mean,
That's what I said. So far, so good. All of us are newbies into this, not more than maybe 2 years since we've really started and we've learned and done that. But so far, so good. That's all I can say. So in our FECO bank paper, we had a 70% reduction. People at 1 year are off drugs. So those who were on 3 or more medications right now. But I'm not sure how long it's going to last. I hope it does. But usually we call about 1 or 2 years of glaucoma surgery success. So we don't talk of less than that. But I suppose it should. And PACG definitely, because that's a trabecular meshwork thing rather than an outflow. So if you can do that, yeah.
So for every procedure like bang, GAT, or MIGS or trabectome,
The more angle you treat, the evidence is the more effective it is. So we've now started doing GAT more often than just a bang, and we hope that'll last longer.
thank you, ma'am.
Well, thank you very much. And with that, we come to this end of this session. Thank you. Yeah.
Thank you to all the speakers and the chairpersons for making this session interesting and insightful. Just before we conclude, I request Dr. Harsh Kumar to give away the token of gratitude and appreciation to give us your time, sir. First, we call upon Dr. Mahipal Sachdev, sir. I would request Dr. Arup Chakrabarti, sir. Dr. Nitika, who represented Dr. Tanuj Dada, sir. I would like to invite Dr. Anil Mandal and Dr. Sushmita. We are sorry there has been a delay from the team to bring in the token of love. I apologize personally, but I will make sure it's handed over to you, sir. We'll all get in for a group photograph.